Reason is quite simple. It takes longer to converge just because it has much more variables, yeah, factor 10 approximately. Why it is so fast per iteration is just that proton dose creates less integral dose. So each beamlet is smaller. Yeah, so each beamlet is smaller. There's much less dose needs to be stored. So the actual multiplication, the actual dose computation in the optimization, it's faster. So just like, I always like to give a little bit of side information for the interested students. Okay. And now we have a proton beam. And this is like one proton beam. And we can already look at the dose, and we see there's basically much more parts of the body are not irradiated, while at the same time we have an extremely smooth coverage, or like extremely good conformal coverage of the tumor. The only thing that is high is here our entrance dose. Yeah, our entrance dose in this example is a bit high because also the path to the target is so short, but it's one beam. I don't have to do any tuning here. And if I open my DVH, this looks already much better than everything I achieved with 5 photon beams before that. Yeah.
There is a question in the
Okay,
chat.
there's a question. Good.
It says, is there any way to change the dimension of the beam cross-section? And how did you plot the proton beamlet?
Is there any way to change the dimension of the beam cross-section? I'm not entirely sure what you mean by that. So basically the lateral, like let's say the size of the beam orthogonal to its entry direction, this is in MATROD or in most return planning systems, this is basically defined by the projection of the target onto the beam's eye view. Yeah, you put a little bit of spots somewhere here, and then you calculate the dose in this. Doesn't make sense to compute a proton spot over here. You can, of course, do this like and change this process in MATROD, but usually people don't do it. You can, of course, if you think about the individual beamlet, is basically defined by the accelerator geometry. If you build a new accelerator, you can also make decisions, for example, on how big this should be. You could basically target certain sizes. For example, for very large tumors, it might make sense to have a bigger beam focus that gives you wider individual beamlets, so you can space them further apart and reduce the time and also computational load for planning. Yeah, that's maybe this targets this question. In most accelerators now have a few of these focus settings. So you have a variety of foci, which means like widths of the individual beamlet that you can choose at extraction of the beam from the accelerator. Yeah, there's the beam optics can be adapted a bit to create these spots of different sizes.
Excuse me, can I ask a question?
Yes.
Is this beam already stretched out, Bragg peak? Is that why the surface dose is higher?
So the spread out Bragg peak is here automatically generated by the optimizer. Yeah, so this is a fully optimized beam of 3000 beamlets, and the spread out Bragg peak is done by the optimizer itself. Yeah. There's also formulas for creating spread out Bragg peaks just by a rule. Yeah, if you have multiple proton levels and you can just calculate it directly. But usually by now, since the optimizer will do it automatically, you just let the optimizer decide. And there was one more question related to the chat question. How did we produce, or how did I in the presentation produce the single beamlet plot? This you can actually do very nicely. This is a little bit of MATROD hacking for the interested. So I can create a new vector, so I can check out how many proton spots I have. This is kind of given here in total number of pixels, it's called. It's 3,571. And I create a vector of 3,571 zeros. Yeah. So this W is now a vector of 3,571 zeros. And I just set the first one to 1. And then what I can in principle do is just do like multiply the matrix with my vector. Matrat has a shortcut for that. And I will not explain this in detail right now, but you find something similar in the examples if you are into the code. I don't know my own program anymore, like this. So I can call this, which does the matrix vector product for me. And now I can refresh. I don't see anything, but now I have to find my single beamlet. Now I have just one of my proton beamlets calculated. Because only one of my beamlets is now weighted with 1, all the others are 0. This, of course, I could plot a DVH. Nothing happens really in this plan. There's a tiny target dose somewhere here. This one beamlet produces a tiny target dose. You see this here, 10 to the minus 6, like 0.002 gray maximum dose. So you see you need a lot of these beamlets to fill up your target. And this is also a little bit outside almost. It's like the first beamlet and is for some reason created somewhere here. There's a little bit of tricks you can do with Matrat if you're interested in such things. I like these for education a lot because you can just play around a bit. All right. So this was the proton plan. I can quickly re-optimize the old plan. So we see that one again. Yeah, let's stop it maybe. And yes, of course, we can still do the same tricks as we did with protons. Yeah. So what we see here, we have a spread out Bragg peak. The entry dose is already high. Yeah. So what can we do? We can do multiple beams. Yeah. It's obviously also possible with protons. But the thing is, we need so much less beams. You can just choose 2 or 3 beam angles if you want. I choose 2. If you are working with me here or online, just choose whatever you want. So let me just do something like this. I use -5, like I'm a little bit lazy. I use -45 and 45. And I always can go through the same workflow. And I think this is like one of these really nice things where like physics and math and computational sciences tie so nicely together because you can abstract the problem from clinical to mathematical description, then to physical simulation, and then to mathematical optimization again. And there's really nice connection points, so you can stick to the same methods and just use different modalities. So I calculated the dose for both beams. I do the optimization. With each beam I add, it gets, of course, a bit slower. There's more data to pass through the computer now. Basically, each of these dots in the optimization replaces the computer at least one time to take the matrix, multiply it with the current result the optimizer has. Remember, it goes iteratively. Then calculating the function, getting the value, getting the derivative of the function, and going to the next step. And yeah, now we have a second plan, and we quite nicely see that a lot of the incoming dose problem is gone because now we just have 2 beams to superimpose, so the entrance dose is much smaller, and so on and so on. Yeah, and of course you could add more beams, but for protons, this you rarely would see anything with more than 3 beams. Yeah, why? Like, why would you use many beams if you can use 3? there is like at the moment, there's kind of a big community anyways trying to do arc treatments, like you do VMAC treatments. You could do the same with particles. It's a little bit more tricky due to something that we will see later. But it's really like seeing a lot of proton beams, individual beams, like not thinking about arc is something that is very rarely observed, because already with 2 or 3 beams, you have a very low entrance dose. A small part of the body is irradiated. You do not want to make this dose path any bigger than it needs to be. So it's very, very low integral dose compared to photons. Yeah, and you see that these I triggered the 3D view. That's not what I wanted to click on, but you can look at your box in 3D, which is not very exciting, I would guess. It also shows where the beam angles come from. But if you look at the DVHs, these DVHs are already great. Yeah, without doing much, you have super target coverage and good organ at risk sparing. Yes. So what's also a thing, like I showed you in the photon case, I showed you this big tweaking of these individual functions. Yeah. To some extent, this is smaller in protons, because in protons and also in ions, it of course then becomes a little bit more, I apologize, it becomes a little bit more important to plan the beams. Yeah. Because here, when you work only with 1 or 2 beams, it really plays a role what you shoot through on your way. Yeah, it would not make sense to plan this beam now from below. You would shoot directly through the organ when you don't have a reason to do it. Like with photons, of course, since you have to use a lot of beams, you will inevitably hit your organs and might not be able to avoid them. So the tweaking step of the functions is very important. While in protons, you might already use a beam arrangement that does 90% of the job. Okay? That's just something to really take away, like from this from this exercise. And I think what I at this point usually like to do is to, before we go to other ions or whatsoever, is to go to a patient case. Patient cases are more fun to plan, I would say. And these are not, this data that we have here is not really actual sick patients, but healthy volunteers. So we are also allowed to have a little bit of fun. So if you, sorry, I'm doing this already on the side. So if you have these things, so what we can do now is that we load with clicking on load MAT data and navigating to the folder we found before. I think it should be now in the correct folder anyways. Otherwise, it's always in your installation directory for the standalone users. And it is in the source directory for the non-standalone users. So let's go here to liver. I like the liver patient because it shows you a little bit more about, it's not overly complicated, but it shows you a bit more about the challenges in treatment planning and also how it is solved in reality a bit. Now, I will quickly deactivate my plan visualization. And then what you can also do, there should be a preset for liver here on the right side, a window preset for visualizing this region of the body. And you see there's now a very strong contrast between the lung and like some contrast that even allows you to see a little bit of heterogeneity within the liver. So for example, here. Where's the isocenter? Let's go. So I think it comes up soon. There it is. So basically what you see here is a theoretical tumor that sits kind of on top of the liver in a sense. So in the upper part of the liver. Again, I'm trying to stay as visual as possible with the terms. And what you directly see when you go to a practical plan and a practical case, you don't deal with 3 contours. You deal with a lot of contours. Yeah, you have to do a lot of contouring. Like in the earlier, you might have, like when I said contouring is like a tedious task. If you have 3 organs, yeah, it might not be. But if you have tons of organs and contours that you want to do, we can maybe try to render this patient quickly in 3D. Then you see it a little bit better. Takes a little bit a while to compute all the surface meshes. If we look at this now here, see there's a little bit more involved. I'm really sorry, MATLAB's 3D rendering is not super good. But I think you see quite nicely that you have parts of the bowel here, yeah, and general the intestines lower here, and you have, let's like scroll a little bit further. I really don't like MATLAB's rendering. This is kind of the tumor here with some extra segmentation. Look at, we have the spinal cord going back here. So you see there's a lot of volumes in here. You can always look at kind of where they are on the CT. So you see here at some point, this seems to be the liver as well. Then you have the heart directly next because the heart lies a little bit like kind of above the liver, right? Touches parts, if you can say, at least regarding to distance. And there's also parts of you can kind of just scroll here through the structures. Oops, I want to get rid of this view and take a look at what you have. And if you look at the names of these structures here on the right side, you see that there's a lot of things that make directly sense. Yeah, so we have a kidney right and left somewhere. The lucky ones of us still have both kidneys. Some very brave people gave one away. Others had to take one out. So, but the kidneys are somewhere here. And there are some weird structures. For example, there is a structure called combined kidney. Like, why is there a structure called combined kidney when you have both delineated anyways? Yeah, and these are then structures that are there for helping the planning, because your clinical protocol might have some dose constraint or some dose prescription on what the combined kidneys should resolve. And that's kind of this practical thing that people then do. Instead of doing the math themselves, they just create a structure of both kidneys that contains both kidneys, and then they have easy access to the dose values in both kidneys combined and the individual kidneys. Yeah, so you have something like combined kidney. Yeah, like the next thing on top, from top of the list, we can look a little bit. We have the stomach somewhere. I think we saw this in the 3D view. So if we go up, the stomach sits. So the liver sits here. The heart sits here. The stomach sits here, right? So that's kind of the stomach here. I'm very bad in showing this. I'm not a doctor. I have never looked into my own body, so I don't know where my liver stomach is. But the stomach you see kind of coming here on the right side of the picture, but the patient, the images are kind of turned around due to the coordinate systems usually used. So you see the stomach here. You see parts of the bowels like going all over the place. Like if you go, this is going up, so we need to go down. You see parts of the bowl, which they look quite funny when you have kind of an actual slice, because they all are all over the place, and so on and so on. And you have then, for example, some weird helper structure. So if we go back to where the tumor was, the tumor is somewhere here. It's this bluish thing, the light blue. That's the clinical tumor volume. I guess you saw these targets in the earlier presentation. So we have the clinical tumor volume, usually a gross tumor volume. or clinical target volume. It's usually, I think there's a GTV here, so we can look for this. It's like very bad color. I need to change the standard color just at some point. So here you see this olive, dark, greenish contour. That would be the gross tumor volume. That's what people see on the images. Then they would assign the blue CTV, which again has some weird, is overlaid by some weird liver minus CTV structure, also used for planning. So all these weird structures, you can turn them on and off by clicking on the check marks right next to them. So basically, here's the GTV, and then there's a region around the GTV, which is called the clinical target volume. What does this mean? So we know that the tumor somehow might be, for example, infiltrating. Like this is a big thing with glioblastoma, for example. These are like very aggressive head tumors, and you see them as like bulk tumors on the image, but you know that they infiltrate the rest of the brain quite aggressively. But you don't see that on the image. So since we know that, there's some infiltration region, like we designate an additional region, but make it anatomically informed. So right here, it does make sense that the liver tumor does not infiltrate outside of the liver. So the liver contour also contours or bounds the CTV. So it is infiltrating here, but not here. And then there's another volume, and this is the one used for planning. It's the planning target volume, the PTV. The PTV basically adds another layer of security around the clinical target volume. So the idea is you see a tumor, you assume clinically some infiltration, and then you have the physical volume you want to treat, that one that's also infiltrated. But then you want to be sure that when you misplace your isocenter by a 0.5 millimeter or something like this, you misplace your patient slightly, that you still cover the tumor. So you add another layer, the planning target volume. And a lot of research in therapy is kind of targeted at making this small extension as small as possible. So high precision, try to have as good as positioning, try to have the latest image so you are sure about the anatomical changes and don't need to assume that the target can be anywhere. So you could think about lung treatments. If the lung moves while treating, you would need to irradiate like a giant region. And we would use something called an ITV, would like irradiate a large region. Then if you can follow the lung, you could basically treat a much smaller region following the tumor and so on and so on. So a lot of research is directed as making this PTV smaller. And it might not have a big effect in this case. You think that this one here is like maybe just a 2 millimeter extension, but to everybody who thinks that like a 2 millimeter extension here might not be that much of a volume, take an orange, peel it, and then kind of just put the what you peeled off the orange, which is just a very tiny shell in a sense, and kind of put it next to the orange. And you see that this is quite some volume that you just peeled off the orange. And it's also like, it's the same like the scam with the 30 centimeter and the 27 centimeter pizza. Actually still some volume that you add or you take away. Yeah. If you can eat a 27 centimeter diameter pizza, you may not be able to eat a 30 centimeter. It doesn't like look that much more, but it is. So that's kind of the thing, like there's large volume attached to these PTV, CTV discussion. Okay, but just with this, let's look a little bit more. Let's not only talk about it, a little bit of talking needs to be done. What you see is also like some really weird volume like this, dose fall of volume. So often in clinical reality, you will add some volumes to help you with something. Yeah, for example, optimizers cannot solve everything. And what they can solve heavily depends on what the vendor has implemented in their planning system. So sometimes you want to have an extra region around the target where you allow higher doses and do not pull them too much down. And how clinical medical physicists do this, if the treatment planning system has no way of doing that, because there is no implementation of a nice function for that, they will just add another volume in this region and try to steer it. So for example, I've seen that people did plans and there was always a hotspot popping up here. Yeah, no matter what they did, there was a hotspot popping up here. What did they do? They just add a volume here, name it dose reduction, and then put a specific function to push down the dose in this region, and then they will have a plan without a hotspot there. So, but that's kind of a little bit the trickery with volumes. So I will turn a little bit of them off. You also sometimes have some localizers in the body, like small clips or whatsoever. We also saw these frame of reference locators in the mask, I think in the head and neck patient in the presentation earlier. So these can also be in the CT in a single voxel, for example. Yeah, you have like kind of weird volumes. I will turn some off. You don't need to turn them off. Will just be a little bit annoying in the DVH later. For example, here you also around the spinal cord, you can imagine the spinal cord is a very sensitive organ you want to avoid in treatment. You have kind of a safety extension, like the cord is here and you have a +5 millimeter safety extension. And this kind of means when you plan, you would plan to spare this 5 millimeter safety ring, and then you can be quite sure that you spare your spinal cord. And that's because a single maximum dose in the spinal cord can be very damaging. Yeah. Like if you irradiate the liver, like you irradiate the liver somewhere here in the body, your right side, and you hit the spinal cord here, you will, and you damage it severely, you might lose all your function in your legs and whatsoever. So definitely worth to put a little bit more sparing on the spinal cord. Okay, so that's kind of how this looks like. So these plans look much more complicated. And so why I also like the liver patient is that it does not give you so much pre-configured. The liver patient is kind of a somewhat minimal setup that you load. For all these contours, you start with 2 functions. So you start with a function on the PTV, that's the function we plan on, and a function on the skin. I have to say that skin here is not only the skin, it's just the stupid naming of this data set. It basically, and you see this quite often, basically is just the whole patient contour. Yeah, skin should, in my opinion, actually mean just the skin layers, but for some reason, it's really the whole patient contour. And so it has like just these 2 objectives, like reach a region in the target and spare the skin. And I would say we start with that. So you can create now a proton plan. I would say we don't do photons, like we have time until when exactly in the schedule? I can look it up, 4 or 4:30?
4:30.
4:30. I guess then we could even do a photon plan. We have some time. So let's do a photon plan. Like start with a photon plan, look for a few beams, 5, maximum 7, if your computer is very good. If you have your gamer PC at home online, you can also use 9 beams. But yeah, I will stick to what I had before. You can choose beams differently if you want, or you can choose more beams. Do not forget to change to photons. Otherwise, it might get a little bit annoying. We can run without sequencing now. It's just for educational purposes in a sense. You do not need sequencing. What I like to do, this makes it a little bit easier to assess the doses later. And also, it's not that unrealistic that you use a little bit fewer fractions for liver treatments. So more higher fraction doses at fewer fractions. So I will go, it's probably still quite a lot, but I will go to 15 fractions. And I have now here something as like, that's like 45 gray and 15 fractions. And this gives me, in a sense, a nice prescribed dose of 3 gray per fraction, which makes it nice to analyze later on. And then you create this plan and you can just start with the setting that you see here. Just to get a baseline plan, you calculate the matrices and look at the result. And there's one thing about these standard beams that could be avoidable, and that's where we can see that sometimes also beam selection for photons could make sense. But let's look at the result of that. It will take probably a bit longer than the phantom to calculate everything and also to optimize. I will just run through that now. Is there any questions in the chat to be answered in the meantime, or is everything nice? Okay. But here's a question. Okay. Yeah, I can do something. What is the question?
Do the angles have to be equally spaced, or can
You can do what basically
Okay.
whatever you want.
Sure.
It's like kind of standard that you start for IMRT treatments with some set of equally spaced angles. You just load them and then you tweak a bit if you see that something is obvious. Yeah. But equally spaced angles is kind of some standard, but it might not always make sense, especially not the ones that I've written down now, which we can discuss. Is there something that is kind of obvious why this choice of angle is not kind of the best idea? Yes. So if I just carelessly select like a set of angles that I always use, I will end up with stuff like this happening. I have a beam directly going through the spinal cord. Like it's really high dose region, directly do it. So maybe this is not the best idea. Yeah? So this is something to take care while setting up the beam angles. And you can do this by kind of visualizing the entrance channels. And for this case, it might actually be maybe somewhat nice, but you never really know. Like in the end, you don't know what the plan will look like. If you have a lot of experience, you know that. You can basically say, I have in my life seen 500 liver patients, so I know how to set up a liver treatment. It's kind of a lot of experience as well, which will be probably also somewhat be replaced by AI. But you can kind of try to rotate this all a little bit away. Yeah, so you could, for example, say if there's now, you could probably try to get 30 degrees out of each angle. Like, I can be a little bit pragmatic about this. I could do something like this. Yeah, and you see, now I have like rotated all my beams a little bit away. You see there's now a mismatch. Still, I would have the problem that this beam coming from here would go through the spinal cord, but it would do so only in the low dose distal region. Yeah, my heart has 2 beams now, but they come somehow. They still try to avoid it somehow, but maybe this might not be so nice. So I could try to give that even like go away from the equidistant setting and try to kind of tilt these angles a little bit. So that's basically how you could think about tweaking angles, yeah, for photons. So now you basically even more go around the heart, not so much spinal cord. So maybe we are much better here. Like I'm usually not doing a lot of tweaking because I'm not involved in clinical treatment planning. But that's kind of the logic of how you do that. And then we can calculate our dose again. Of course, whenever we change beams, we also need to recalculate the dose. So a question that I often get is, yeah, why don't we optimize the position of the beams as well? And there are methods to do this. There are optimizers and some, I don't know how many commercial there are, but there are some ways to do that. So we need to recalculate, need to re-optimize. There's some fun, interesting results. So like for photons, the results are often that, yeah, there's a little bit of a change to what humans choose. Sometimes there's a little bit a slight 5-degree shift for a few beams, but often it comes up with similar beams. Then you have the VMAT situation that you often just do VMAT, so you do one rotation, There are some interesting approaches to also rotate the couch at the same time and get some very optimal arcs and non-coplanar arcs to the patient.